score could be a little bit higher, but not to a level that you are worried. And their PSA isn't doubling or isn't increasing in the time that you're monitoring them. So you just want to observe them. You don't want to start any therapy. You don't want to do anything that's going to induce any more symptomology or things of that nature. Those patients that have a little bit of a higher PSA have a Gleason score that is a little bit higher, as well as they're having symptoms, maybe some urinary hesitancy and things of that nature, but they don't necessarily feel as if that they want to start therapy just yet, because this is definitely a conversation between the provider and the patient. Whether or not the patient wants to start therapy, we actively surveil them. What does that mean? That means that we get PSAs probably every 3 months. We get serial biopsies maybe once a year just to make sure that they aren't progressing, and we watch these patients a whole lot closer. Our observation patients, we don't see except for maybe once every 6 months. Our active surveillance patients, we probably see once every 3 months. For those patients that actually have true prostate cancer within their prostate, we have 2 different treatment modalities that we'll use as long as they don't have any other tissue involvement. The first treatment modality that we'll use is radiation. In the pre-class lecture, we talked about radiation coming in 2, technically 3 different kind of forms. We can do external beam radiation, so that's your standard radiation where you kind of go into a machine and you get radiated from the outside. And then there's internal radiation, which is a seed that's implanted into the prostate. When that seed gets implanted, it can either be a continuous exposure to radiation, so low bursts of radiation coming out of that seed throughout the entirety of that treatment course, whatever the radiation oncologist decides is that treatment course. Or it could be a large burst of radiation for a shorter period of time, and then that implant has to be taken out. Another option that we have to offer patients is radical prostatectomy with or without pelvic lymph node dissection. So what that means is that we're just removing that prostate in totality. And if there's any lymph node involvement, then they'll go ahead and take those lymph nodes out too, just to be able to control the disease. These patients that we start with radiation and pelvic lymph node dissection and radical prostatectomy will also be actively surveilled. Chances are, as long as the disease is confined within that prostate, we are probably not going to start systemic therapy, because systemic therapy offers extra cytotoxic properties or extra toxic properties to patients that we don't necessarily want to expose them to until we absolutely have to. This takes us over to systemic control. Now, generally patients will present with a localized control sort of mechanism or present in a manner where we can employ that localized control. But sometimes patients will wait and they won't come into our oncology offices in that time that they actually need to, so they have a little bit more spread disease, but it's not metastatic. It's just outside of that prostate. So what we do then is we employ all of the systemic control factors that are also at use. So this is used for individuals that have disease that spread outside of the prostate in and of itself. So when we look at our 5 blocks of therapy for initial treatment, this also includes short-term ADT. So we would definitely employ radiation and the surgical resection of the prostate, but we're also going to offer them some therapeutic factors that will allow for us to get that tissue that's around the prostate as well. So what does short-term ADT mean? ADT in prostate cancer, I know you guys have seen this slide before, but I'm going to go over it again. So testosterone is a major source of fuel for prostate cancer. As you see in this picture here, testosterone is built from a couple of different sources. The primary source is the pituitary source. So 95 to 97% of our testosterone that's made in the male's body is made through the hypothalamus-pituitary axis. So the hypothalamus gets stimulated by LHRH or GnRH, which induces the pituitary gland to release LH and FSH. LH works on those Leydig cells to produce that testosterone, and then the testosterone gets translocated into the prostatic tissue and induces growth in both the PSA, growth in the cell in and of itself, and then increased survival of the prostate cancer. This means that testosterone is that fuel that increases the prostate cancer and grows that tissue within the prostatic area. ADT's goal is to cut off that testosterone source and prevent that testosterone from being able to let that prostate continue to grow and survive in a cancer sort of manner. The goal of ADT is to make sure that our testosterone levels in the body are less than 50 nanograms per deciliter. This is just a normal lab test that we will get on most of our patients that have prostate cancer and are undergoing treatment. There's a couple of different ways that we can offer ADT to our patients. Surgical castration is probably one of the least favorable ways because that's a very, very permanent mechanism of reducing testosterone in our patients. Another word for surgical castration is an orchiectomy. We can also do GnRH agonist plus an anti-androgen. This is called combined androgen blockade. And then we can do GnRH antagonism for our patients. So we're going to go into the last two therapeutic factors that we can offer our patients.
Just a quick update, Dr. Patel. The quiz is posted, so you can assign folks to take it whenever you're ready.
Okay, cool. Let's move back. Let's go ahead and take the quiz, and then we can run through the rest of the treatment-related things, and then we'll get into our cases. So, like I said, the quiz is, the password is ribbon, nothing's capital, spelled normally. So we'll give you a couple minutes to just do that real quick. Ribbon? All right, I think it looks like the majority of the people over here are done. Is that true for the other campuses as well?
No.
No.
Everybody's done in Albany.
Awesome. All right. Let's wrap that up, and we're going to go ahead and move on to the rest of our talk about GnRH agonists as well as anti-androgens and GnRH antagonism. So, GnRH agonists are goserelin, acetate, leuprolide, histrelline, and triptyline. Of these four agents in practice, we generally use leuprolide the most, and then goserelin acetate is probably the second most used agent. Histrelin is not really often used, and neither is triptyline unless we absolutely need to, meaning the patient's insurance won't allow us to use the first two. What GnRH antagonism does is it stimulates the hypothalamus to release that GnRH. So we're actually putting GnRH into the body. That means that the anterior pituitary is going to be releasing all that FSH and LH to produce the testosterone. This drug, or these series of drugs, really plays on that negative feedback loop that's associated with testosterone and that HPA axis. What will end up happening is at some point, probably a week or so into therapy, the testosterone will be so fulminantly present in the patient's body that the hypothalamus pituitary axis will shut down and will prevent it from actually, prevent the testosterone from actually being formed. But in that period of time, that week to 2 week period, there is an increased level of testosterone. And every time there's an increased level of testosterone, we're inducing more PSA, more growth, and more survival. So patients are having more symptomology. So a lot more urinary hesitancy. If they've got bone involvement, they're having a lot more pain, a lot more fatigue. All of those symptoms that happen with prostate cancer are just flared up. We call this tumor flare. To prevent tumor flare, we add anti-androgens into the mix. We're going to go over the mechanism of action of anti-androgens in the progressive disease state because it kind of fits in a little bit better. But what we do with these anti-androgens, bicalutamide, flutamide, and lutamide, is we add them on for about a week prior to the start of the GnRH agonist, and then we continue that for another 2 weeks while they're still on the GnRH agonist. GnRH antagonists are not often utilized in practice unless a patient has exceptional, like a really, really bad prostate cancer. So they've got lytic lesions in their bones, they've got prostate cancer in their liver, the systemic factors of the disease have spread significantly. So what this agent does, Degareless is the name of the agent, what this agent does is it inhibits GnRH from ever being formed or ever producing that FSH, LH, and testosterone increase. So this is a full stop. In patients that are inpatient, so they're having really, really bad disease, we put them inpatient because we need to support them additionally, but they need treatment for their prostate cancer. This is the agent that we're going to use so we don't induce that tumor flare and make their symptomology even worse. Some of the things that we want to watch out for when we introduce these agents into patients is that we want to watch their bone mineral density. So patients will have a DEXA scan at baseline, and then we'll get DEXA scans every 2 years while they're on therapy. We'll monitor serum testosterone levels to make sure that they are maintaining less than 50 nanograms per deciliter, because we want them at that castration level in order for this agent to actually work. We'll watch out for diabetes because we are messing with that hypothalamus pituitary axis, and that messes with the cortisol and factors like that that is also being produced. And then the patients are generally at an increased cardiovascular risk. So a lot of these patients will also be on cardiovascular related drugs. Some acute events that'll happen is that tumor flare with that agonist if we do not introduce that combined androgen blockade. Gynecomastia is a factor, hot flashes, erectile dysfunction, edema, and injection site reaction. A lot of the acute effects that you want to think about when you're introducing these to patients and counseling patients on it is a lot of the things that you would tell a patient if they were having hot flashes or menopause. Long-term effects are osteoporosis, which is why we do that bone mineral density. Clinical fractures can also happen because of that osteoporosis. Obesity, insulin resistance, alternation in lipids. So we monitor their triglycerides and things of that nature probably every 3 to 6 months, depending on what the patient's status is. And then metabolic syndromes can also happen in these patients. Unfortunately, even though prostate cancer has a really, really long 5-year survival rate of like almost 94%, it does generally tend to progress. So we initially treat these patients with our localized therapy. We give them a prostatectomy, we give them some radiation, and hope that puts them at bay for a little while. We introduce some level of therapy with our GnRH analogs and maybe possibly combined androgen blockade, and that puts them at bay for a little bit longer, gives them a couple more years. But then that PSA increases, their testosterone sometimes increases because it gets refractory to these medications. There's resistance mechanisms that happen with every single medication that we put into the body. So then their PSA starts rising, their disease gets worse, and we have to introduce additional therapy. Some of the ways that we know that patients are having progressive disease is we check testosterone levels on patients that are on therapy. So if their testosterone level starts to increase, that means that they are refractory to the treatment that we're providing, and we need to change our treatment to induce that testosterone level that is less than 50 nanograms per deciliter. A big factor that we watch out for in my clinic is a PSA doubling time. That's what that PSA DT is. So what that means is the time that it takes for the PSA to double. So let's say patient came in January, his PSA was 2. Okay, I can deal with that. Patient comes in April, and his PSA is now 4. That is a less than 6 month PSA doubling time. That means that the patient is going to have progressive disease. Although those PSA numbers are low, and I probably wouldn't make any changes, in patients that have those higher PSA levels that double into the 20s and the 30s, we want to introduce therapy in a more progressive manner at that point in time. Patients that are undergoing progression will also have increased symptoms. So they're going to have increased urinary symptoms with that hesitancy, not being able to hold a stream. They're going to have bone pain, most likely, and then there's going to be changes in their liver function tests because this disease tends to metastasize to both the bone and the liver. Treatment options for progressive disease are within these 6 blocks. I know you guys have seen these 6 blocks before. The one option that we have available is androgen withdrawal therapy. The whole premise of androgen withdrawal therapy is to remove everything that we're giving to the patient to try to re-stimulate the patient's natural mechanism within that hypothalamus pituitary axis, thinking that maybe we're over-treating the patient to like restart, jumpstart that system. Unfortunately, androgen withdrawal therapy probably only works in about 20% of patients and only works for 2 to 3 months, even if it does work. So that's why we have all these other agents that we can provide. We have anti-androgens that come in 2 different forms. So the first form that we're going to be talking about is the androgen receptor inhibitors. So there's 2 generations of androgen receptor inhibitors. The first generation is the one that we use first. So first generation androgen inhibitors, anti-androgens are bicalutamide, and nilutamide. These guys, when we look at this picture, are presented in that orange diamond looking thing. this one right here. So what they do is they inhibit testosterone from actually being able to bind to the androgen receptor within the nucleus and without even outside of the cell. Our second generation anti-androgen receptor inhibitors are enzalutamide and apalutamide. Enzalutamide has these agents have a little bit more umph to them. So what that means is they inhibit that testosterone activity through a variety of different mechanisms. So first of all, they inhibit the testosterone from ever being able to bind to that androgen receptor on the surface of the cell. If the testosterone has already been able to bind to that to androgen receptor and be translocated within the cell, it prevents it from actually being able to be translocated into the nucleus. And then if it's already bound to the DNA, it inhibits it into the DNA as well. So enzalutamide also lacks that partial AR or androgen receptor agonism activity, so it inhibits that surge that can possibly still happen with bicalutamide, flutamide, or nalutamide. In the pre-class lecture, we went over some of the dosing schemes associated with these agents. Bicalutamide is the agent that we utilize most often in practice. The brand name for this agent is Casex. Flutamide can be utilized if bicalutamide isn't available for patients, but it is 3 times a day dosing. And because prostate cancer is generally a disease state that doesn't make patients feel very badly, they're not very adherent with the medication. So making sure that we're offering them options that don't necessarily have all of that extra burden of taking extra pills throughout the day is a good option. Nalutamide is only FDA approved if a patient has an orchiectomy, so we don't generally use that agent. Out of enzalutamide and apalutamide, enzalutamide is the agent that's most often used, and that's purely because insurance companies like enzalutamide better than they like apalutamide. It's just more easily accessible for patients. Anti-androgens that are enzymatic inhibitors of androgen, or the androgen synthesis system, are also options. So these are our newer agents, and these are abiraterone and ketoconazole. So what these agents do is they go in and inhibit key enzymes within the whole system of making testosterone. So they're not messing with that hypothalamus pituitary axis by any means. They're working with the enzymatic factors. So abiraterone is the one that I'm going to focus on because we rarely ever use ketoconazole. Abiraterone inhibits CYP17A1. So as you see, CYP17A1 plays a pretty significant role in the production of a variety of different androgens. Abiraterone allows for the inhibition of that CYP enzyme, and thus we're not producing testosterone. So if we're not producing testosterone, we can't increase that PSA growth and survival. Chemotherapy is another option that we have to offer our patients. So the two regimens that we utilize for chemotherapy are docetaxel and prednisone, or cabazitaxel and prednisone. So docetaxel and prednisone would be the first chemotherapeutic agent that we utilize in patients. The way that this works is it binds to tubulin and interferes with the disassembling of the microtubules. The adverse effects associated with docetaxel are rash, fluid retention, stomatitis, so mucositis in the mouth, oral diarrhea, myelosuppression, and hypersensitivity reactions because it's made in a polysorbate 80. This requires pre-medication with dexamethasone to prevent that fluid retention and hypersensitivity reaction. Cabazitaxel binds to tubulin as well, but it's generally reserved for patients that have been refractory to docetaxel, so it's like a second-line therapy for us, or actually a third-line therapy for us. And some of the adverse effects associated with this are neutropenia. And I'm bolding neutropenia because that is probably one of the most aggressive adverse effects for cabazitaxel. Patients can also have neuropathy, some level of anemia, leukopenia, and thrombocytopenia. Some of the pre-medications required to prevent hypersensitivity reactions are the same as docetaxel because of that same polysorbate 80 component that is actually needed to mix the product. Prednisone is added to these agents because we need to make sure that the patients are having some sort of a cortisol boost in their system to allow them to still produce the other androgens that they need to produce. Immunotherapy is another option So the main immunotherapy that I want to go over is Sibutol-T. I mentioned this briefly in the pre-class lecture. The mechanism of action is more of a vaccine sort of system, which causes the immune response to attack the prostate cancer. It's administered in 2-week intervals for a total dose of 3 doses. And some of the adverse effects are infusion-related reactions, chills, fatigue, and nausea and vomiting. We generally reserve this for metastatic castrate recurrent disease and then asymptomatic or minimally symptomatic patients. The last thing that I'm going to go over very briefly is radiation or radium-223 that we can utilize in patients that have bone metastases. These patients that we use this radium-223 in is patients that don't necessarily have any other symptoms but just have bone metastases. So we want to radiate those areas and not expose them to all of the systemic therapy that we could possibly offer. So, in the next 2 slides, I kind of have some treatment algorithms to figure out what treatment levels that we want to go to. So the first question that we generally ask ourselves, is the patient metastatic or not? If the patient's not metastatic, I'm going to go with the GnRH agonist or antagonist with or without the combined androgen blockade. If they are metastatic, I'm still probably going to think that I'm going to go GnRH agonist or antagonist if they haven't seen it before. Or I'm going to do ADT with docetaxel for 6 cycles or ADT with abiraterone and prednisone for an extended period of time. Other treatment algorithm for castrate recurrent patients or castrate resistant patients is to ask the same question, is the patient metastatic or not? If they're not, then you want to ensure that they have castration levels of testosterone, and then you want to try a secondary hormone therapy. So let's say leuprolide didn't work, let's try goserelin. If they are metastatic, then you want to try to give them treatment that's kind of specific to where their metastatic disease is. So maybe if they have bone metastases, then give radium-223. If they want to try immunotherapy, then we can offer Sibutol-T. And if they have any visceral mets, so metastatic disease in the organs like the liver or in the abdomen, then we can do docetaxel. Abiraterone with prednisone is also an option, but generally, if patients have full metastatic disease, we would do a more aggressive therapy with docetaxel or chemotherapy. Okay, I threw a lot at you guys in a very short amount of time. Do you guys have any questions so far?
Yeah.
Yeah.
I had a question about the quiz.
All right. Okay, so we're going to move into the cases. We have 3 separate cases, but each case kind of has a couple of different parts to it. So I'm going to try to assign groups to certain parts of the cases. So work with me here and tell me if it's working. If it's not working, we can try to figure something else out.
What's her name?
So our first case is BF, who's a 61-year-old male. He has been receiving prostate cancer screening every 2 years. At his 2-year follow-up, his PSA was 12 nanograms per milliliter, and he had an abnormal digital rectal exam. What are the next steps for this patient? So I am going to assign this to group number 3, and I'm going to give you guys like maybe 5-ish minutes to work on it, and then we can discuss it, if that's okay. Thank you.
So it's minimized. It's minimized.
We would do a prostate biopsy and then assign a Gleason score and TNM staging. And that would help us to identify his risk group and guide our treatment.
Okay. So group 3 said that they would do a prostate biopsy to determine the Gleason score, allow for risk stratification with TNM staging, and that's absolutely true. So there's very stepwise factors that we have to take with oncologic patients, and the first thing is that we need to know how bad their disease state is. So in order to figure out how bad their disease state is, you need tissue, especially in your solid tumors. So tissue is always the issue. Keep that in mind. All right. Any questions on that?
Yeah, we're not.
All right. So moving on with our patient case number 1. BF is still the 61-year-old male. He still has that PSA of 12 and that abnormal DRE. His prostate biopsy was positive for adenocarcinoma with tumor involving more than 50% of only one lobe, and a Gleason score of 4+3, which is 7, as we remember from our pre-cost lecture. So the questions that we need to answer here are: what are his risk factors? What is his risk stratification? What is his life expectancy? And then what treatment would you offer? So I am going to assign this one to group 14.
Dr. Patel, there are some folks in another campus in Augusta who have a question. Their microphones aren't working, so I'm going to ask the question.
Absolutely.
So they want to know, there was a question on the quiz, one of the options was an orchiectomy plus nilutamide, and they want to know why that was the wrong answer.
Oh, yes, absolutely. So generally, we want to try to preserve as much function as we possibly can in patients. So taking a more permanent stance by doing an orchiectomy and going with nilutamide is probably a less favorable option than actually going with an androgen blocker and bicalutamide or flutamide. Does that kind of make sense?
That's not what she asked.
What's the answer? But the question was asking what FDA.
So what was the right answer? Because I also put that answer. I thought the question was asking like which two went together or like improved together. And you have to do those two.
They're
together.
like, we can do it here.
Yeah, absolutely.
Okay, I'm confused.
But
Give me
they
just a second.
can't.
I'm going to pull it up so I can see it as well.
What's her name, Dr. Patel? Yeah. Isn't she working on someone's question? She's done. Huh?
Just answer.
Just say Dr.
had a question
Dr.
in
Patel.
Augusta.
She can't hear us.
But also, like, these have to go together.
Can you hear us in Augusta?
Whereas Marjorie called it yesterday, deafening silence.
They hate us.
I like that.
You didn't doubt
Can you
it.
hear us in Augusta?
That's why we kind of late, because everyone was like,
Hey,
just leave.
I am still looking for my document. If you guys want to work on this case as an entire class real quick, and then group 14 will be the one that will be presenting on it, I will find this document and then we can go over that question. Is that okay for right now?
These have to go together. The other one, you can use Vic alone, and you can use the other one.
Yes.
But the
Okay.
nilutamide has to go with his orchiectomy. So that's why I was like, that would be correct, right? And that's the one that was not. I didn't know flutamide. It was the one that was not right.
Yeah, the other three
And
are
I was
all
trying,
things
and I was
that
trying to say, okay, Julie is not.
I think we just all need to like create a bunch of questions to where she has to figure it out, okay? Just keep asking questions. Nicely.
What is that?
Just keep asking questions nicely to make her realize that there's a lot of questions. No, you're not, but when they get out of work.
Wait, all the other things are there?
And so then,
Why are they all in Athens?
Okay, so.
have a cycle just go. I mean,
I didn't have to go today.
I'm not
and
going.
then know
We're working on cases.
it's okay, if they can't call on us, that's all right. Yeah, just leave it, we won't be able to answer for case questions, it's all right.
There was another campus that didn't have Wi-Fi yesterday, so.
Yeah, after class.
We usually start our meeting early, so don't feel bad. How do you figure out a patient's Wi-Fi?
Like if they're old.
We need to go to the home.
She was tapping.
Isn't that just
Well, we can hear it.
They turned Augusta's volume all the way down.
Mr. Chris here?
He's not there.
That's why Chris is the magic worker.
Chris is not there either. Chris isn't there. It's just Sarah trying to do all of this.
That's okay.
Yeah.
There's no such thing as stuff.
They're working.
We thought she was ignoring us. Yeah. And we're like, oh. And it's green up there, so.
Yeah, don't worry about it.
Yeah, Sarah's not answering my mom. The little days out. How was this days out?
Oh, thanks for the invite.
I wouldn't mind if I wanted to make it decided
I recommend him. No, not him. I know him. He's from undergrad. He's in all the science classes. Then I never saw you in undergrad.
Jenny, I'm going today.
Oh, let's go.
I need to call and make an appointment to make sure it's there.
Are you going to
and you would have
She's
sliding in, lickety split in your DMs. Yeah.
She can do quite all SNS. She can't do all right. It's easy.
So much,
Also, the
lickety
owner,
split.
she told she's really good at SNS.
I'm not going to get it. I'm just going to get like this jump and
I feel like she doesn't read me.
Dr. Patel, I want the student who got so much question regarding the quiz. I was curious as to why it was flutamide and coriacetamine was incorrect because I read that question as a combination that package is used together. And it was my understanding that you would not see a flutamide or alpha.
There's also a third answer that was still a.
Yeah,
Yeah, I did take away that the bifo-flutamide and GnRH agonist combination was the preferred.
She said she would address it after class. She needs to find her document.
All right, do you guys think that we have some answers for this case?
How would you answer our questions first?
Okay. Before we get into the answers in the case, I have my document pulled up, and you guys brought up a really good point. I think that I messed this question up. So,
Say not a little bit.
different right answers on this one. So there was bifenthramine and GnRH agonist. There's flutamide,
That was
GnRH
said very
antagonist.
loudly.
There's merlutamide and orchiectamine, and then D is apalutamide and GnRH agonist. The two wrong ones are the flutamide and GnRH agonist, or antagonist, because it's only approved with an agonist. And then apalutamide and the GnRH agonist are also not approved together. Apalutamide is just given with an antagonist.
No, that's wrong.
What we
Right here.
will
It's
do
just
about
agonist
that
with
is I will talk to Dr. Clemens and figure out
What is
a
she
solution
talking
to
about?
that one. But we can go over that one in a little bit more detail in the class. So, if group number
Dr.
14
Patel.
Yes.
On your pre-class slide, it says that apalutamide is given with the agonist.
It is, I'm sorry. I think that I am messing this one up in totality.
Just take it
So
all.
we'll just talk about this one at the end of class, if that's okay?
Yes, thank you.
Thank you.
Uh-huh.
Oh, our mics are working now.
Okay, so group 14, let's do this patient case number 1. What are BF's risk factors?
So, I'm sorry, would you like us to go through the entire thing since we have all that time? Or just the risk factors?
What the heck?
Sure. Okay, so for this patient's risk factors, we determined that because this patient is proficiently advanced age, around 61 years old, that would be the reason to suspect an increased risk for prostate cancer. Other things may also increase this risk, but we don't know, including family history, race background, potential involvement in Vietnam War. But regardless, we decided to put this patient in the intermediate stratum, particularly because of his Gleason score, 4 plus 2, or 7, which places him in the moderately differentiated category. And we have that nice handy little table that shows us what that means and what we can do based on this patient's, expected lifetime.
Annoying. As hell.
Expected risk is lifetime, so expectancy is. So, patient 61 years old, kind of a toss-up whether he's going to live more than 10 years or not. So we went ahead and went safe and said over 10 years. So we decided that it would be best to treat with either EDRT with or without short-term DBT, with or without brachytherapy, or doing the RP with PLND with or without, and also potentially brachytherapy allowed.
Awesome. You guys did a great job. So we'll just go over all of those real quickly. So BF risk factors are definitely his age. If he was African American, that would also put him at a greater risk for it. Like you said, we don't know about his family history just yet, because we haven't asked all those questions, but if he has a family history, then that would put him at a higher risk for attaining prostate cancer. Risk stratification-wise, there is an intermediate risk, thanks to that nice little table. That table also tells us that the patient has a life expectancy of greater than 10 years, so you're absolutely spot on with that. And then I just put one treatment option that I would offer, but you're absolutely right with you could do a prostatectomy, but radiation with short-term ADT could possibly offer the patient a little bit less of an invasive approach to providing therapy. With the short-term ADT, we would likely do a bicalutamide and leuprolide combination for a short period of time, get castration levels, and then back up on treatment.
Dr. Patel?
Yes.
On that chart, it tells us what therapies do if they're over 10 years expected survival or less than 10. How do you know which is which? Because under intermediate, it has both.
Good question, because I didn't know either.
So under intermediate, you're saying that there's EDRT plus short-term ADT plus or minus brachytherapy or radical prostatectomy and pelvic lymph node dissection. Is that what you're asking? Like, which of these options do you actually choose?
No, how do you know if the survival is less than or greater than 10 years? Because we don't have any classification for that in the PowerPoint.
Ah, that makes sense. Okay, so the less than and greater than 10 years actually goes on the patient's clinical picture. So what they're looking like plays into a strong factor of the less than or greater than 10 years. In terms of individuals that are generally fit, younger individuals that are closer to that 50 or 55-ish range, we put them in that greater than 10-year category. Patients that are looking frail, that have a little bit more symptomology from their prostate cancer or have additional comorbidities, fall into that less than 10-year group. Does that answer your question?
Yes, thank you.
Mm-hmm.
Would you also put someone at less than 10 years, just if they're at advanced age?
So that's a catch-22 question, especially with our oncology population. There's individuals that are in their 70s and 80s that are still very, very fit and very active. If that's the case, then we would probably treat them as if they were going to be in that greater than 10-year category, even though their life expectancy, just based on their age, is probably less than 10. Does that make sense? I'm getting some weird looks here.
I have a question. How would that be presented like on a test? Would you tell us life expectancy?
I would not ask a question like that on a test. This is a very fluid sort of factor. The life expectancy would be, for this patient, he's 61 years old. So that puts him at a younger category, right? He's generally fit. He's been receiving his prostate cancer screening every 2 years, which kind of gives you a picture of, okay, so he hasn't been needing continuous follow-up. at his 2-year follow-up is when we find that his PSA is a little bit higher. If I was gonna put this question on the test, I would also put a lot of like symptomology factors. He's not having any urinary hesitancy, he's not really having bone pain, he's not really complaining of all of this stuff. This is just a finding that we found on his lab work. Does that make sense? Okay. All right, any questions with this case or any additional factors? Okay, we are going to move on to our next case. Our next case is Mr. TZ. He's a 72-year-old male who presents to the clinic with metastatic prostate cancer. He's currently receiving Leuprolide 22.5 milligrams intramuscularly every 3 months with bicalutamide 50 milligrams daily. His PSA has risen from 1.2 to 4.3. His past medical history includes hypertension. He's on amlodipine 5 milligrams daily. His blood pressure in clinic today was 126/82, so well managed. Type 2 diabetes. He's on metformin 500 milligrams twice daily. His blood glucose in clinic today was 165. He also has atrial fibrillation, so he's on metoprolol ER. His heart rate in clinic was 72, and he's also on warfarin 5 milligrams Monday, Wednesday, Friday, and 2.5 milligrams on Tuesday, Thursday, and his INR today is 2.3. Hyperlipidemia, on atorvastatin 40 milligrams daily, and his pain is managed with tramadol 50 milligrams every 6 hours as needed or paid. The plan is to discontinue that bicalutamide daily and initiate enzalutamide 160 milligrams daily with continuation of that leuprolide. You have been consulted by the oncologist to evaluate the drug therapy. What interventions do you want to make? What are the key counseling points for the patient? And what are your monitoring recommendations? Are there any supportive care recommendations that you have for this patient at this time? I'm going to give you guys maybe like 5-ish minutes to work on this, and then I'll assign it to the group.
When Corey teaches us breast cancer, it's not an action trainer.
she was getting a submit to work on this case before she actually picked a group.
Bye.
Dr. Reagan also put out time and name therapy.
Correct?
Oh my gosh. Oh, did she really? Yeah. Oh, that's because she asked me to tell her to do the survey. I think you obviously, okay, it's a struggle. She tried.
What did you say?
Audrey or
Angry. She said angry slaughter.
All right, do we think that we have some answers to this?
No.
There's a drug interaction with warfarin and second generation androgen receptor inhibitors, so we want to look into that. For counseling, there's an increased potential for fracture and seizures while on the medication. Also, take this medication by mouth 4 capsules at one time with or without food. For monitoring, we want to monitor bone mineral density, serum testosterone, diabetes, and CVD risk. And for supportive care, we give supplemental calcium and vitamin D. And if he's at an increased risk for osteoporosis, denosumab.
What did we not get?
Okay, you guys were right on the dot with all of that stuff. So the interventions that you want to make sure, especially when you're starting a new therapy on a patient, is that a med-rec is probably the most important thing that you can do for a patient. You want to look for drug interactions, you want to look for things that could increase renal toxicity or hepatotoxicity depending on the agent that you're utilizing. So for us with enzalutamide, there's a drug interaction with warfarin, atorvastatin, as well as amlodipine. So it reduces the efficacy of these agents, so we need to make sure that the patient is aware of the fact that his INR is probably not going to be appropriate, and there will be adjustments that need to be made with the warfarin. As far as the amlodipine and the atorvastatin goes, the atorvastatin can be up titrated because it's only at 40 milligrams. That is also dependent on the patient and their cardiologist, though, so that communication also needs to be in play. Amlodipine, if its efficacy is reduced, we're going to see that with the blood pressure increase. So we want to make sure that the cardiologist also knows that they're going to have to titrate the amlodipine to efficacy for this patient. There is a increased seizure threshold, or increased seizure potential with this drug. So tramadol also has a reduced seizure threshold, which means that maybe tramadol isn't the best pain management option that we have for this patient, and maybe we need to provide him with another option for his pain management. Some of the counseling points, like you mentioned, were fatigue, hypertension, so that's going to lead us to believe that amlodipine is already going to have to increase in therapy, or we might have to add additional antihypertensive medications. Hot flashes, because we are messing with that anti-androgen or the androgen pathway, GI side effects, a little bit of musculoskeletal pain really only happens in about 5% of the patients receiving this therapy, and then seizures. Seizures are something that they saw in the study that initially allowed enzalutamide to come onto the market, but it happened in less than 2% of the population. So those patients with an increased history of seizure in the past they're on agents that decrease their seizure threshold. We just want to make sure that we're monitoring them extremely carefully. Or we want to find another agent to provide them with. Some of the monitoring recommendations, like you guys said over there, is the CBC with differential and liver function tests at baseline and then periodically. Periodically usually means like every 3 months when they come into clinic. And then monitoring the blood pressure. We usually tell our patients within the first 2 months of therapy that they need to come in with a log of their blood pressure that's measured at the same time every day, and preferably not after they have gone for a long walk or not after they've done a lot of strenuous activity. The supportive care mechanisms that need to be employed for almost every single patient that has prostate cancer is a calcium and vitamin D supplementation, because they're already at an inherently increased risk of attaining bone metastases, which makes your bones weaker, which means that you can possibly have a fracture. Allowing for calcium and vitamin D supplementation means that we're just making those bones a little bit stronger and allowing for patients to possibly avoid the fracture risk. If the patient had increased risk for this osteoporosis, like you guys mentioned, you would do Zoveta or Xgeva, denosumab. Since he has castrate-resistant prostate cancer, if he had bone mets, we would definitely introduce this agent. Any questions on this case?
Would you also do a DEXA scan for the monitoring?
Absolutely. That is something that I didn't put on here. But yes, you want to get a DEXA scan before you start therapy. Preferably, since this patient's already been on bicalutamide and an agonist, you want to make sure that they already had a DEXA scan from baseline and nothing's been changing. That happens every 2 years. So we get it before we start therapy and then do it every 2 years afterwards. Any other questions? All right, we're going to move on to the next case. So patient case number 3. Mr. W.E. is a 62-year-old male with castrate-recurrent or castrate-resistant prostate cancer. He has been on Leuprolide 22.5 milligrams intramuscularly every 3 months with enzalutamide 160 milligrams daily since September of 2017. He presents to clinic today. This is what his PSA trend kind of looks like over this time period. So in June, he had a PSA of 1.96. In September, he came back with a PSA that had doubled to 4.5, a little bit more than doubled, so we started enzalutamide therapy. His PSA dropped to 2.3 in December, but now in March, he has a PSA of 5.4, which means that we're progressing again. He has a bone scan from 1 week prior, and it shows no bone metastases. His past medical history is hypertension, type 2 diabetes, and peripheral neuropathy secondary to his diabetes. His current medications are lisinopril 20 milligrams daily, Lantus 30 units at home, Novolovin units 3 times a day before meals, and then duloxetine to help with that peripheral neuropathy. The plan is that the oncologist wants to start abiraterone 100 milligrams daily. I want you guys to create a pharmacy plan for this patient that kind of mirrors the same plan that we did before. What are the recommendations for his prostate cancer treatment, including the additional therapies that you feel that the patient may warrant, some counseling points for the patient, as well as monitoring recommendations. So I'll give you guys another 5 or so minutes to work on that. So switch over. All right, so looks like everybody's wrapped up around here. So we're gonna assign this one to group number 17. So whenever you guys are ready, just present on this, please.
Huh? That's us.
You what?
She just decided it's us.
Aaron, did she say 17?
Yeah.
Aaron.
This
what's
is
the
us.
answer?
Oh. Shit. Will we add prednisone to this? Sarah? I think we should add prednisone twice daily to this. Wait, what was the question?
Do you have any counseling points for the
Oh,
patient?
shit. Okay.
I don't
know.
get on an empty stomach.
He needs to take it on an empty stomach.
Thanks, Curdy.
Curdy, speak like you're group 17.
Anything else that you want to tell?
Go ahead, Curdy.
What did you say? Hypertension? What else? Hyper.
Yeah.
Where are you reading this?
You can see hypertension, hyperglycemia, high triglycerides.
Yeah. You're all good. Any monitoring recommendations that you would have?
Monitor blood pressure. What is CMP? Monitor blood pressure, complete metabolic panels such as hypokalemia, liver function tests. We also want to monitor for adrenocortical insufficiency because this could cause issues in patients with diabetes. We want to monitor blood glucose and A1C to ensure control of this.
Absolutely. So,
Get to work, team.
You guys did a really good job on that.
Thank you,
These are
guys.
some of the recommendations that I came up with for this patient.
Thanks,
So
everyone.
the recommendation would be to add prednisone 5 milligrams twice daily to the patient's regimen, as well as the abiraterone. The reason for prednisone is to help re-stimulate that cortical pathway that is getting messed up by inhibiting that CYP17A1. Now, if you guys notice on the pre-class lecture, abiraterone has two different mechanisms or two different indications. So it can be used in metastatic castrate-resistant prostate cancer or metastatic castrate-sensitive prostate cancer. The difference between those two is that metastatic castrate-resistant prostate cancer occurs or progresses even despite castration levels of testosterone. So the patient can have a kind of testosterone level of less than 50, but their PSA will still be doubling. Those individuals in the study that brought this to the market for that indication got prednisone 5 milligrams twice daily. As far as metastatic castrate-sensitive prostate cancer, those are the individuals that have a testosterone level that is higher than 50, that we can still dial back their testosterone by giving them a different type of agonist or antagonist and putting abiraterone on as well. These individuals get 5 milligrams once daily of prednisone. And that was just primarily because of the way that it was studied. There is really no true evidence saying that twice daily of prednisone versus once daily of prednisone makes a difference in patients. We just have to have some sort of a prednisone added onto the patient's medical regimen because of that cortical pathway that is inhibited by these agents. The counseling point, or other things that we want to make sure that we're adding on for the patient are bone-modifying agents like denosumab or Zometa. Calcium, vitamin D in these supplementation, as well as maybe some pain management because he's probably going to have some level of pain if he's having recurrent disease. Counseling points, like you guys said, was definitely to take this drug on an empty stomach. It's 2 hours after or before a meal is just kind of how I remember it. Fatigue, hypertension, increasing blood glucose, GI side effects, respiratory symptoms, and hepatotoxicity are all adverse effects that you want to explain to the patient. The monitoring recommendations are the blood pressure and the blood glucose, so we want to make sure patients are bringing logs of both of these to clinic visits. LFTs with AST, ALT are very important, especially with the bilirubin, every 2 weeks for the first couple of months and then monthly thereafter. Serum potassium, because this drug can cause hypokalemia, is important because you might need to do some sort of potassium supplementation. So, any questions about this case so far? Alright, so we're going to move on to the second part. He returns in 8 months after starting week therapy for follow-up. His repeat staging scans now show extensive worsening bone metastases. He's now requiring scheduled morphine for bone pain, and he wishes to continue working and desires to avoid significant toxicities. So which of the following options are best for this patient and why? I want you all to try to figure out why each one of these would be either good or bad based on what you know about prostate cancer so far. So I'm going to give you guys about another 10 minutes to work on this, and then we'll go over it. All right, it looks like everybody on this side is almost done with it. I'm hearing a little bit more chatter, which is good. So let's go ahead and go through why each of these options are either good or bad. So if group 25 would present what they think, that would be
Whether it's his last day of work, same company, but it's in a different department. ADP. I don't know, it's for the payroll. That big glass building. What's that road called?
We said we preferred radium-223 because of the bone metastasis.
Absolutely.
And symptomatic.
Yeah, that's absolutely correct. So you guys definitely hit the nail on the head. Why did you say that docetaxel or prednisone wouldn't be a good idea?
He doesn't have visceral metastases yet.
Perfect. Same sort of symptom with the, same sort of factor with the mitoxantrone prednisone? Okay, all right, so good job. So docetaxel and prednisone is an option for patients that have visceral metastases. When we think about metastatic disease, we think about, in prostate cancer, we think about bone metastases and liver metastases. Those are our two primary sites of metastases. So if a patient were to show up with liver metastatic disease, their LFTs are rising, they're having increased symptomology, we would start them on docetaxel because they're having aggressive disease. Another reason why we don't want to start docetaxel and prednisone in this patient is because they only have bone metastases. Docetaxel doesn't have good bone penetration or CNS penetration, so it wouldn't be as efficacious as that radium-223. Mitoxantrone and prednisone, if you look at the NCCN guidelines, is an option for treatment in patients in a very, very last line setting. But it doesn't show any benefit in overall survival. We're not extending the patient's life by actually introducing this therapy to patients. So why give them cytotoxic properties and cytotoxic therapy if we're not going to increase their life? Radium-223, like our group said, is the best option as it's shown improvement in the setting of bone metastases, and it's a more of a localized treatment option that we can provide this patient. The vaccine or the immunotherapy with Sibutol-T is usually only used in asymptomatic or minorly symptomatic disease, and in all honesty, we've only used this in 2 patients that I've seen at EUH. So, rarely ever used. Any questions on this stuff? All right, we'll move on to our last one of the day. So he received 6 treatments of radium-223 and had relief of bone pain and tolerated the therapy fairly well. Unfortunately, his PSA is continuing to increase, and new staging scans show liver metastases. Which of the following options are best for the patient? Is it enzalutamide, docetaxel prednisone, mitoxantrone prednisone, or a repeat course of the radium-223? Alright, this one's pretty similar to our last one, so you guys think that we're ready to present on it? Okay, if group 7 would present on this one, please.
She needs like a line how we bars to start out this day. Going on what short?
We would use docetaxel and prednisone.
Alright, that is absolutely correct. So, for our patient, docetaxel prednisone is definitely the best option that we can offer because he's symptomatic, he has visceral metastases, he's got progressive disease, despite all of this other stuff that we've done to him or given to him. And so we need to get his disease in control quick. So docetaxel prednisone is the quickest way for us to definitely do that. Mitoxantrone prednisone, like we talked about before, doesn't increase his survival, so why would I give that to him? The radium-223 works for his bone metastases that has no evidence within visceral metastases, so that's not going to be efficacious. Enzalutamide is an alternative option that we can offer him, but it's not preferred as it doesn't provide that quick control that we want in a disease that's rapidly progressing.
More?
Does that kind of make sense? Okay. Any questions on this case? Alright.
Oh my gosh, y'all are
And I
hilarious.
lied, I have one more. Sorry. WE will now be receiving monthly denosumab injections. Which of the following are true? There's multiple answers that are true. Okay. In group 20, would tell me which of the ones were right. We can wrap up our class.
We said everything was right except for should receive denosumab 6 milligrams every 6 months and not monthly.
Absolutely, that is 100% correct. So we want to monitor any patient that's getting either Zometa or denosumab for osteonecrosis of the jaw. Osteonecrosis of the jaw, if you Google it, is a real nasty condition that can occur in patients that are having any sort of dental work, even a simple cleaning. So patients that are receiving these therapies need to not receive these therapies within 3 months of getting the agent, or getting dental work done. So if they're getting dental work done in June, we stop the denosumab 3 months before and don't start it back until 3 months afterwards. Denosumab, as we mentioned in the pre-class lectures, is a RANK-L inhibitor and is probably more beneficial in our prostate cancer patients just because of the way that the disease state works and the way that this drug will inhibit part of that lytic lesion formation in the bone that leads to those metastatic factors. Denosumab has been shown to delay the time to first skeletal related event, so that's a fracture, whether it's a compound fracture or a simple fracture, in patients with bone metastases, especially in our prostate cancer patients. So we preferentially utilize denosumab over other agents. And then WE should receive denosumab 60 milligrams sub-Q every 6 months, not monthly. It's really dependent on the formulation. So there's actually 2 different brand formulations for denosumab. One is Xgeva, and that one is given 120 milligrams sub-Q every 4 weeks. And then Prolia is the other formulation, which is given 60 milligrams sub-Q every 6 months. Generally, we will start patients out on Xgeva first. If they're doing well, we will switch them over to Prolia if their insurance allows us to do so. Any questions on that?
As far as dosing, what would you like us to know for the exam?
That's a very good question. So I think specifically focusing on our anti-androgen dosage factors, especially taking into consideration how many times a day you're supposed to take it, with or without food, drug interactions. I want you all to know that. I'm not going to expect you all to know too much of the dosing of the GnRH agonist and antagonist, just because there's a variety of different dosing formulations. Timing of it is very difficult and different. I want you guys to focus on the ones that are more like standard. If we were to start this agent, we're going to start it at this dose for this duration of time, or at this frequency. Does that kind of make sense? Let me see, what else? I give you no dosing considerations for any of the chemotherapies, such as docetaxel, prednisone, cabazitaxel, prednisone. You would just be asked about regimen-specific factors and not dosing-specific factors. All right. Any other questions that I could answer for you guys in relation to anything we went over in class? Okay. Now, as far as the quiz question goes, the quiz question was supposed to say which of these treatment options is not FDA approved. And for that, there was one answer that was right. So those other 3 answers, if you guys put the other 3 answers as right, then I'm going to talk to Dr. Clemens and see if we can accept all 3 of those answers, or we'll throw out the question in totality. Is that fair? Okay. If there's any other questions, I'll hang out here for a little bit longer. You guys are more than welcome to email me. I think my email is plastered on every single one of these slides, so please reach out for anything that you may need. All right. Y'all have a good rest of the day.
I have a question, I guess.
Yeah, what's up?
For the quiz question, I know I had seen that 3 of them were right and then 1 was wrong, so I just put the wrong one since I thought that it was supposed to say not, or that one was the odd one out. So I was wondering if we could get credit.
Yeah, well, you just throw out did that, email me and let me know. I'll talk to Dr. Clemens and see which way she wants to go with it.
Throw the question out.
No. I will.
You get credit for it. Yeah.
We will talk to Dr. Clemens and see which way we're going to go with it. But just email me if you decided to think that the question was written inappropriately.
You decided to think. Well, now everybody's going to be like, yep, I decided to.
All right. Thank you guys.